So this is actually a pretty big challenge because you've had a whole morning of macular degeneration and now I get to do everything else in 15 minutes. So this is going to be a little bit of a whirlwind. I'm not going to cover it all, but we're going to talk about some of the topics here for the aging eye. And there's a lot that happens as the eye ages, obviously. It's a tissue that requires a lot of oxygen. It requires a lot of work throughout your life. And so it's not surprising that some of the structures do get some wear and tear. So we're going to be talking not about macular degeneration, which is the first point there. You guys are already getting that covered. We're going to talk more about cataracts. We're going to talk a little bit about glaucoma, which is my area of specialty. And then we're also just going to touch on two other things that are common questions, which is posterior vitreous detachment or floaters, as well as the dry eye. So these are all really common and very, very frequent questions that we get. So hopefully this will answer some of those questions you guys have been wondering about that were aside from macular degeneration. So this is actually a photo of my grandmother, who is 94 years young. And that is her holding my 2-week-old son. And she has just had cataract surgery about a month before this picture was taken. So there's so much technology and so much ability. And she had her cataracts taken out by a local physician up in Wausau. And you can see her sporting her new glasses there and getting quite a good view. So without further ado, let's talk a little bit about cataracts. So prevalence. As we all are aware, the prevalence of cataracts really increases as we get older. So this shows it very nicely that at 40 years of age, very few people are diagnosed with that problem. And then as we get older, that prevalence, that number of people who are affected just goes up and up. The percentage goes up and up until we hit 80 years plus. And at that point, the prevalence is as high as 60 to 70%, depending on which population we're looking at. So very, very common disease, and most people are affected by it as we age. A similar looking graph is actually the prevalence of glaucoma. So we also see this going up and up and up as we get older. Very uncommon in that 40-year group, but as we get to 80, much more common. Now this scale is very different than the cataract scale. This is only going up to a high of about 15%. So the most prevalence we get versus 60% in cataracts is only about 12% in glaucoma. So much less common disease, but we see that same increase in prevalence as we get older. And so what does this mean for us as a population? Well, we have aging eyes in an aging population. So that means that our population here in the United States, as we get older, is going to have more and more eye disease. And so we as eye care providers are doing our best to keep up with the number of patients that are having eyesight and eye problems. So as you can see here, this is actually from 2010 census data. So this is a little bit old at this point, but is the newest that we still have. And you can see this is in alphabetical order, so macular degeneration comes first at about 2 million. We've got cataracts affecting about 24.5 million people in this age group above 40. Diabetic retinopathy is about almost 8 million, and glaucoma is near 3 million. So this is a lot of people that are affected by these diseases. Cataract is a disease of the lens. It's a clouding of the natural lens of the eye. So you can see from this anatomy picture, we've got the schematic on the left-hand side. I'm going to try to use the pointer here in the center, but hopefully you can follow along on all of the screens. So we have the front of the eye, or the cornea, which is nice and clear. And then we have the anterior chamber, which comes right behind the cornea. The iris tissue, which is the colored part of the eye. And right behind that, through the pupil, we see the lens, the natural lens of the eye. And when we're born, that lens is nice and clear generally, crystalline, so we can see through it, and it focuses the vision back onto the retina, which is what you guys have been talking about all morning, back onto the retina here and on the macula. Unfortunately, sometimes we develop cataracts, and this is a pretty extreme example. Where you see the pupil is dilated, and in the center of the pupil you see this brownish or yellowish structure with kind of snowflake opacities, and this is a pretty advanced cataract. This is what a person with cataract might experience with their vision. They usually describe it as things just being blurry. The words can be a little bit out of focus. It feels like they need an update prescription in their glasses sometimes, or like someone's put a little Vaseline on the glasses, or possibly that there's a fingerprint on the glasses. I've had it described that way as well. As it progresses, vision sometimes will look more yellow, so whites will get a little more of a yellowish color. And patients frequently will describe problems with bright lights. So a very common description we get with patients who develop cataract is that they get a lot of glare. Oncoming traffic causes a lot of glare with headlights, or maybe sunlight causes too much glare and they can't see when the sun is really bright. Alternatively, they also need a lot of bright light. So as the cataract develops and the vision becomes a little more dim, you need more and more light to be able to see. So what do we do about cataracts? Well, there's some preventative things you can do, but not much. You can avoid UV light throughout your lifetime. Now, this is a hard thing to tell a patient who's already developed a cataract because the damage has been done by the time you get to this stage. But it is something that I tell my children or try to keep them in sunglasses when we're out in a sunny day. You can also try things like antioxidants and just living a healthy lifestyle. But ultimately, cataracts become a surgical problem. And so we take care of them through surgery. So this is just a schematic or a showing of what it looks like when we remove those cataracts. We make a small incision into the eye, and then we go into the front of the eye with a very small probe called a phacoemulsification handpiece. And this is actually, I tell patients, and this is maybe not the best analogy, but I tell them it's a little bit like a tiny jackhammer. So we use ultrasound power and kind of very small pulses to break up the lens, and then it's attached to a vacuum, and we pull those pieces out continually while we're doing the surgery. It's a very elegant surgery. Smart people have developed this over time and made advances, and it's constantly improving. At this point at the UW, we also offer laser-assisted cataract surgery. Now, if patients ask me, can I get this done without actual surgery? The answer is still no. We have to do surgery. We're still making some small incisions into the eye, but we can use a laser to assist us if that's a preference. We're also currently getting all of our residents trained in this, so that's something we're very proud of, that they'll all be certified with laser-assisted cataract surgery. And then on the right-hand side, you actually see the lens going in. So once the cataract or the clouded lens comes out, we put in a new lens, which is usually acrylic, a kind of a plastic lens. We can taco it. We make it into a smaller package so we can insert it through a small incision, and then it goes into the eye and it unfolds. And it's really a miraculous moment in surgery. And I think this is when somebody who's a medical student or still deciding what they want to do sees this process unfold, it's just amazing. So I want to talk now a little bit about glaucoma. Sorry, I jumped ahead. Glaucoma is actually my area of expertise. I do cataract surgery, but I'm also a glaucoma specialist. Glaucoma is a kind of confusing disease at times, but when it boils down to it, it's really a disease or a degeneration of the optic nerve. So we're looking off to the side a bit here. Here's our schematic again on the left-hand side. The light is coming through the pupil, hitting the macula, and then all of these retinal cells are collecting that data and pushing it through to the optic nerve. So here's actually a fundus photo. So this is a photo of the back of the eye. Again, this is the macula and all of the retina with the blood vessels. And right here is the optic nerve. This optic nerve is basically a bundle of cells that are collecting all of that information from the retina and pushing it back to the brain. And so this is a very important structure, obviously. What we see in optic nerve in glaucoma is that the optic nerve degenerates or changes over time. And so right here on the left-hand side, this is a normal optic nerve, and we're blowing that up to a larger scale in these pictures on the right. That first one is actually a very normal optic nerve. It has a very small pit in the center, and so we say it doesn't have much cupping. So we actually call that little divot in the middle a cup. And a person who has a very small cup generally doesn't have glaucoma. Over time, the disease of glaucoma can cause an increase in that divot or an increase in that cup. So the next picture over to the right actually has a much larger cup, so that divot has kind of grown in size, and there's less healthy tissue along the rim or on the edge of the optic nerve. And then finally, on the far right-hand side, we have advanced glaucoma. So this optic nerve actually has no healthy tissue left around the side. It is all divot or all cup at this point. And so this would be an example of someone who has very advanced glaucoma. So what about eye pressure? Everyone thinks of glaucoma, or frequently we think of glaucoma and we think of eye pressure. It is the most significant risk factor for glaucoma, and it's our only modifiable risk factor, meaning this is how we treat glaucoma, is to lower the eye pressure. Eye pressure goes up due to an outflow imbalance. So the eye is made in a way that there's a drain, a natural drain that runs around the front of the eye and acts kind of like a grate or kind of a filter. We call this the trabecular meshwork. So I'm going to blow that up here. It's off to the side there. And then this is a very large drawing of the trabecular meshwork. And you might see it's kind of like a filter. Over time, unfortunately, that filter becomes clogged and the pressure can go up in the eye. And so that's how we treat glaucoma, is actually to lower the pressure to try and slow the progression of the disease. People often say that glaucoma causes tunnel vision or a loss of peripheral vision. I don't think that's true for most of my patients. So this is kind of a common schematic or a common depiction you might see if you Google vision loss in glaucoma, and this looks like tunnel vision. But truthfully, when I ask my patients what they're seeing, when they're coming to me for the first time or with advanced disease, they say my vision is fine. Generally, I don't really have any problems at this point. And that's very common. So this is actually a different artist depiction of what glaucoma might look like. And it's actually a much scarier depiction, I think, but much more true to what patients experience. And so in the upper left-hand corner, this is all vision in the left eye. And down here, this is an actual peripheral vision test that we do at the time of looking for glaucoma. And this patient has normal vision up in the left-hand corner. They're seeing everything in that photo that's happening. Here, this patient has moderate glaucoma, and they have a loss of the vision towards their nose and inferiorly. And unfortunately, it almost looks like a normal picture. If you hadn't seen the picture before, you wouldn't realize that you're missing elements from that photo. And finally, in the bottom, we have advanced glaucoma with a loss of that peripheral vision. And if you looked at that, you might say, well, that might be normal, because the brain fills in the areas that you're not seeing. Until the disease is very advanced, the brain will fill in the vision. So it's very different from what people experience with cataract or macular degeneration. It's called the sneak thief of sight for a reason, and that's because people just really don't notice this vision loss until it's very late. So what do we do for glaucoma? As mentioned before, we're lowering the eye pressure. This is really the only way to treat the disease at this point. And so we treat it, first of all, with eye drops. That's the most common first line of treatment, and this lowers the eye pressure. We can treat it with laser, where we actually are putting laser energy into the natural filter we talked about, into that trabecular meshwork, and that helps open it up. We can also do traditional surgeries where we make a filter. We actually create a new opening in the eye so that fluid can escape through this small trap door, and that's in that upper right-hand corner. We're making a small filter. And then here on the bottom right, if you don't mind pressing play again, Jessica, on the bottom right, this is actually a patient that has just undergone cataract surgery, and we're looking through a specialized gonio lens into that outflow that we looked at earlier, and I'm making a small incision with something called the Cahook dual blade, where we're actually removing a strip of tissue, and we're moving that strip of tissue so that we're opening up that drain further. Also very important in glaucoma is to catch it early. So we do recommend an eye exam for anyone over the age of 65, as we know that prevalence does increase. Most people are getting their eyes examined in this age group anyway because of cataracts and other eye disease. If you have a family history, especially if you have someone in your family went blind from glaucoma, required surgery for glaucoma, or needed treatment very early in life, these are all very big risk factors for you. So you should definitely have it looked at and make sure that your optometrist or your ophthalmologist knows about that history. And then also African American and Hispanic patients, we generally recommend earlier and more frequent exams for them because they do have that higher risk and higher prevalence. Finally, I want to touch on just two other eye diseases that I know we get a lot of questions about. How many people in this room have had floaters before? Yeah, those are really, really common and really, really annoying. So I thought I better talk about that just a little bit. So floaters are caused by the vitreous jelly in the eye, which is basically filling all of that empty space. When we're born, that is very clear and a very solid material. As we get older, it kind of liquefies, it slumps down, it gets little opacities, little areas in it that are clouded. And unfortunately, as the light hits those areas, it leaves a shadow on the retina, and we experience that as small floaters in the vision. At some point in our life, usually around 60 years of age, we get a posterior vitreous detachment. And what that means is that that jelly has now completely separated from the back of the eye, pulled off of the nerve, and kind of created it's really kind of slumped down and not attached anymore. People frequently experience this as a very big floater. They might also get some flashes of light with this, and it is a time where you're a little more at risk for things like a retinal tear or bleeding inside the eye. And so we do recommend usually an exam when that big floater comes on. Unfortunately, the treatment for floaters is generally nothing. We just reassure patients that they generally go away, they generally improve with time. I know some people have floaters that have never gotten better probably, but the vast majority do improve over time and are just less noticeable. And finally, dry eyes. Dry eyes are also a very, very common problem in the aging eye, so I just wanted to touch on that quickly. Basically, there's a lot of causes for dry eye. The tear film is a very complicated substance created mostly by tears that are made by the eye, go down and cover the surface of the eye, and then go through the punctum, which are little holes over here, into the eyelid. That fluid, that tear film, is just a part of the tears, though. We also have mucus that's produced that also holds the tears on the eye, and we also have oils that the eyelid produces to kind of keep the tears from evaporating. All three of those things are very important and are treated when somebody develops dry eyes. Blepharitis is also a common cause of irritation and pain in the eye, and that's generally because of inflammation along the eyelid. So we treat the dry eyes usually by replacing the tears. We recommend using artificial tears, lubricating eye drops throughout the day. We can even prescribe medicated drops that help your body make more tears or make them stick around longer. We can put little plugs into the tear outflow system. And we can also recommend warm compresses or even antibiotics or something to decrease the inflammation around the eyelid itself. That's all I have for you today. Sorry about that whirlwind, and I'll be happy to answer questions later.